Hello, everybody. It's my pleasure to welcome you to today's Olea Academy webinar on susceptibility weighted imaging. It's presented by Professor Paul Parizel and hosted by Olea Medical. First, a short technical review. All your mics will be muted, but you are encouraged to participate via chat. I will submit your questions to Professor Parizel at the end of the presentation. With that, it's my honor to introduce Professor Parizel, David Hartley Chair of Radiology at Royal Perth Hospital and University of Western Australia. He is a distinguished member of the international radiology community, served as president of the European Society of Radiology, among other titles, and has received multiple prizes and honors during his career. He has an extensive expertise in neuroradiology and magnetic resonance imaging, and an impressive publication record on these fields. Today, Professor Parizel will discuss susceptibility weighted imaging, how to understand the principles and avoid the mistakes. Professor Parizel, you can start when you're ready.
Thank you very much. It's a great pleasure. It's not only a pleasure, it's an honor to be here in this Olea Academy. I hope that you can all hear me well, and that you can enjoy together with me some of the sights of Western Australia. You see starting from the bottom, the beautiful beach at Cottesloe, the campus of the University of Western Australia, which is one of the most beautiful, if not the most beautiful campus in the Southern Hemisphere, the Neurology Research Building, the Fauna and Flora, which is immediately near the entrance of the hospital where I work, and then our most famous inhabitant in Australia, the kangaroo, and a nighttime vision of the city. Perth is a city of about 2.5 million people. It is wedged between the Indian Ocean and the Swan River, and it is, I think, the most beautiful place to live, and it certainly has been the safest place to live in the past 1.5 years, because we do not have COVID here. Now, our topic today is going to be susceptibility weighted imaging, and I chose a subtitle, How to Understand the Principles and Avoid the Mistakes. And that's what we are going to try to do in the next 25 to 30 minutes. I do have some disclosures that you can see listed here on this slide, but I don't think that there's actually anything that will have a conflict of interest in my presentation. This is the order of business of today. We're going to start with looking at the definition. What is susceptibility weighted imaging? Then we will look at how it began, how it works, what are the clinical applications, what are some of the problems and limitations, what about calcium, what about the future, and then just a few take-home messages. This is the Black Swan. Perth and the Swan River is, as far as I know, the only place in the world where black swans are found. And black swans are very appropriate because on susceptibility weighted images, we are going to be looking at black dots. As you can see in the logos on the right side of the slide, the black swan is represented in the logo of the University of Western Australia that says Seek Wisdom, and in the logo of the Royal Perth Hospital that says Servio I Serve. So let's start with a definition. What is susceptibility weighted imaging? And I like definitions because it helps us to understand what we are talking about. So there's a few important elements in this definition. Susceptibility weighted imaging is a high spatial resolution, fully flow compensated, 3D gradient echo sequence that combines both magnitude and phase information. And it exploits local magnetic field differences between tissues. This is a 7 Tesla image, very high resolution, showing beautifully the veins within the brain and the veins on the surface of the brain because of the paramagnetic effect of deoxyhemoglobin. So that is our definition of susceptibility weighted imaging. Again, high resolution, flow compensated, 3D, gradient echo, and combining magnitude and phase information. All of these elements are important. Now, how did this begin? Well, historically, MR imaging has relied on differences in proton density, T1, T2, and T2 star relaxation parameters of tissues. In the late 1990s, it became clear that susceptibility differences between tissues could be utilized as a new type of contrast in MRI. And signals from substances with different magnetic susceptibilities compared to their surroundings lose phase coherence at sufficiently long echo times. That means that phase imaging offers a way of enhancing contrast in MRI. And that realization happened more than 25 years ago and was first published in a landmark paper published in Radiology by Jürgen Reichenberg, a German PhD student who was at that time working in the United States and who came up with the idea of using that sequence to look at small vessels in the human brain. And he coined the technique MR venography, so looking at veins. And as you can see from the diagram on the right side of the slide, you see that this sequence is actually fully flow compensated in all three directions, the read, the phase, and the frequency. And so that you get your echo in a three-way compensated fashion. Now, it turned out that there was not a great clinical need to look at veins in the brain. And please take a look at the last person on this paper, Mark Hakey, professor of medical physics and engineering. And he came up with the idea to recoin this sequence and call it susceptibility weighted imaging. This was published in Magnetic Resonance in Medicine in 2004. And as we can see, the authors are now Mark Hakey as the lead author and Jürgen Reichenberg as the final author. And it is under this name that we now know the sequence of susceptibility weighted imaging and that it became famous and successful. And here are some examples. So you can see an axial section through a posterior fossa in a patient with collateral circulation. Look at the T2 weighted image, which is high resolution, doesn't actually show you anything. This is a 3D T1 weighted image, showing that there's not really much abnormal contrast enhancement. But if you do the susceptibility weighted imaging, you see beautifully these collateral structures on the surface of the cerebellum. You can see them here. It opened up a new world, and it was basically what diffusion weighted imaging did 10 or 15 years earlier. It gave us a new way to look at the data that we acquire. So how does this work? I've already showed you a sequence diagram, but we should remember, and I must tell you that these images are taken from the website MRI Questions, how to make an SWI image. So in a gradient echo sequence, you can get both magnitude and raw phase images. These raw phase images are never represented. You will never find them in your PACS system because, as you can see, they are prone to artifact. Now, if you run these images through a high-pass filter, you can get something that is known as a filtered phase image, and that can be used to make a phase mask. The next step is to multiply the magnitude image with the phase mask, and you do that n times to get a susceptibility weighted image. Typically, on most systems, 3 Tesla systems, these susceptibility weighted images would have a slice thickness of 2 millimeters, and they look, as you can see in this image. But the big thing is that you can put a number of these slices together and make a thicker image. And that thicker image, in our system, typically 16 millimeter slice thickness, is now known as a minimum intensity projection. And what you do is you actually collate all of the vascular structures in a thick slice. And this is very similar to what we do in MR angiography. But in MR angiography, we look for the highest signal. Here we look for the lowest signal. And what you can see in this image is that you get a map of the venous system of the brain, the veins containing deoxyhemoglobin. Now, the key here is this high-pass filter. I'm not an engineer. I've always had an interest in this, but I'm not an engineer, and I'm not sure that I could explain this any further than what I show you here. So a high-pass filter is used to pass signals with a frequency higher than a certain threshold, a certain cutoff, and it attenuates or eliminates signals that are below that cutoff frequency. And in this way, you can get this filtered phase image, which then can be used to make a phase mask, scaling data from the filtered phase images. And then the next step is, as I told you earlier, to multiply the magnitude image with the phase mask, and you do that a number of iterations to get the susceptibility weighted image here in a patient with a hemorrhage in the right parietal lobe. So in summary, and even for those of you who don't have a technical interest, it is still important that you should at least remember some of this to understand the danger, the potential, but also the pitfalls of this sequencing. So your image is made in a three-step process. Step one is to remove the low frequency components from the phase image with a high-pass filter. Step two is to create a phase mask where pixel values have values between 0 and 1, and then to multiply the phase mask with the magnitude image and repeat that n times. And then you can collate these thin slices, bring them together as a thicker slice, and we call this a minimum intensity projection, usually averaging over at least 4 images, but sometimes 8 images or 10 images, generating a thicker slice. So when we obtain susceptibility weighted images on our system, we have 4 sets of images. The magnitude images, which show background tissue with proton density-like contrast, and we save them for diagnostic purposes. And the phase images, which undergo a number of iterations, raw phase, filtered phase, phase mask. Then the susceptibility weighted images, which are the multiplication, and the minimum intensity projections. And this is what you get, and this is from a paper that I did with one of our fellows 10 years ago, published in the American Journal of Radiology. So magnitude image, the phase map, the susceptibility weighted image, and the minimum intensity projection. And you can see that this magnitude image, and also to a certain extent the phase map, has a sort of contrast behavior, almost like a proton density image. But please notice that you do have some flow related enhancement, and this is inflow in arteries. And when you look at the minimum intensity projection, all the vascular structures basically become black. Let's look at an example of a patient, an elderly patient with pre-existing chronic small vessel ischemic disease. You can see that there's a lot of dilated perivascular Verco-Robin spaces in the basal ganglia and also in the subcortical white matter. And this elderly patient has developed a subcortical hemorrhage in the right parietal region. These are the 3D FLAIR fat-saturated images showing a lot of small vessel ischemic changes. This is the diffusion weighted image. And of course, this hemorrhage is black because it spoils the spins in that region. And then on a T1 with gadolinium, you have to look hard. I mean, you can see it, but it's not quite as obvious. Now, here are the 4 sets of images that we get with the susceptibility weighted imaging. So we have magnitude, phase, susceptibility weighted image, and minimum intensity projection. And I put in the top row the images through the basal ganglia. Just look at the behavior of the small perivascular Virchow-Robin spaces, look at the behavior of the CSF in the ventricles, and at the relationship between cortical gray and subcortical white matter. And here at the bottom, you see the images through this right parietal subcortical hematoma, and which is dark on 3 of the 4 sequences, but has a sort of pepper and salt appearance on the phase map. Now, please remember when you look at this, all the images in the yellow square are 2 millimeter slice thickness, whereas the minimum intensity projections are actually 16 millimeters. And you can, in your scanner, you can change that as you wish. These are the scan parameters that are given in the literature, and at the right, this is what we use at Royal Perth Hospital in Australia. So we use a TR of 27 milliseconds, a TE of 20 milliseconds, and a flip angle of 15 degrees. And we can do that because we're using a 3 Tesla. And higher field strength allows you to make a shorter TR and a shorter TE and a smaller flip angle. If you are working at 1.5 Tesla, you will probably need these values to be a little bit longer and the flip angle to be a little bit larger to get the signal to noise ratio that you need. And this is from our system, very similar to what I've shown you already. And again, on the minimum intensity projection, you get this beautiful venogram of the deep venous system in the brain with the septal veins, the thalamostriate veins, the internal cerebral veins, the atrial veins, and also the veins overlying the cerebral hemispheres. Now, different vendors have different variants of susceptibility weighted imaging, which is a problem. Because it is very hard, if not impossible, to compare this sequence from different vendors. And here you see a different vendor, and even the names of these sequences are a little bit different, and also the appearance of the image is different. Now, what many people don't really understand is why are susceptibility weighted images and gradient echo images so different? Because susceptibility is basically a 3D variant of gradient echo. And the answer is that susceptibility weighted images are based on gradient echo, so that is the same, but they and gradient echo sequences, gradient echo sequences are sensitive to differences in tissue susceptibility because they do not refocus spins. So why are they different? Why are they different? And the answer is that, first of all, susceptibility weighted images are acquired in a 3D mode. So you can get thinner slices, smaller voxels. They are fully flow compensated in the frequency, read, and phase directions, so you have fewer artifacts. And in the susceptibility weighted image, you can combine magnitude and phase information, and you can display that information separately, and you can process it separately, or you combine everything into one image, such as the minimum intensity projection. Let's now look at a few clinical applications. And I would like to start with one of my favorite quotes from Mark Twain: "To a man with a new hammer, everything looks like a nail." And that's what we've seen happening in the past 15 years with susceptibility weighted imaging. people have been using that sequence for just about everything. Detection of hemorrhage, certainly. Traumatic brain injury, okay. Vascular malformations, arterial stroke, cerebral venous sinus thrombosis and venous infarction, neurodegenerative diseases to look for iron deposition, brain tumors to look for detection, diagnosis, and follow-up and treatment response. All of these applications, and it seems like every day or every month, there are new applications coming. So we're going to look at a few of these applications. This is one of the oldest papers published in AJNR 2007 by Mark Hakey himself, the master himself, who was using this to look for amyloid angiopathy. And if on the requisition form it says query amyloid angiopathy, then there is a monosynaptic reflex that we would automatically do susceptibility weighted imaging to look for these micro hemorrhages, all the black dots that you see. And in retrospect, you can see some of the larger ones on the gradient echo, but certainly the minimum intensity projection gives you like a new and clearer view on this. Other example, microbleeds, posterior fossa. I show you what I think are pretty good high resolution 3 Tesla, T2 and FLAIR images through the posterior fossa in a patient. I let you look for a moment to find out if you see something, do you see anything abnormal? And here are the gradient echo images. And these are the susceptibility weighted images. And of course, you can see these 2 black dots. Now, some of you will tell me in retrospect, maybe I can make out something here and maybe I can make out something there. But it's certain that gradient echo, and especially 3D gradient echo, gives you a new insight into what's going on. We've used this sequence at the University of Antwerp, where I was previously working, to look for cerebrovascular malformations, congenital malformations. This is a patient with Sturge-Weber disease, and you can beautifully see these abnormal vascular structures along the wall of the left lateral ventricle, and you can see the dilated deep veins here. And these are the gradient echo images. And on the gradient echo images, again, if you know, you may surmise that there could be something here, but it's very difficult. We make use of the deoxyhemoglobin in the deep cerebral veins to make this beautiful map of the deep venous system. And this is very similar on a 7 Tesla system in a patient with a small capillary telangiectasia. And of course, you understand that this was first billed as a technique for venography, but it can actually do a lot more than just show the veins. And what it does beautifully is it shows hemorrhage. This is a hypertensive 54-year-old male, suffered hemorrhagic left thalamic CVA, and there was a small hemosiderin-laden cleft within the left thalamus, most likely of hypertensive etiology. These are the turbospin echo T2s, coronal T1s, and coronal 3D FLAIR. These are the diffusion weighted images with the B1000 image and the ADC map. And here are the gradient echo, the SWI, and the minimum intensity images. And as you can see, this looks a lot bigger than what it looked like on the T1, but the blackness that you see is actually not a real anatomic feature. It is an artifact, which is the power of the technique. And you can also see that there are a few black dots here, probably micro hemorrhages occurring in the right thalamus. There are important clinical implications to look for this, especially in patients with a suspicion of amyloid angiopathy. And you can see here a head-to-head correlation between gradient echo and between the susceptibility weighted image, and I point out the lesions to you there. Internal cerebral vein thrombosis, people have been using susceptibility weighted image to look, for example, for a venous infarct in the thalamus following occlusion of the internal cerebral vein, and you can see the example here on the image. And a big area of application has been traumatic brain injury, especially in patients with diffuse axonal injury. Here you see, for example, a number of small punctate hemosiderin deposits, and just compare with the gradient echo T2 star image. If you look really well, you can make yourself believe that you see two dark spots here, maybe one there, but this is very difficult, and it is just so much better and so much easier to see this. So if this sequence is so fantastic, what are the problems and what are the limitations? Well, there are some intrinsic limitations of the technique. That is, the acquisition time is relatively long, leading to movement artifacts. It is prone to air tissue artifacts, for example, near the frontal sinuses or near the petrous bones, and susceptibility artifacts such as the bony structures, the skull base, which can distort image findings. If you want to use a slice-by-slice method for counting the number of lesions, this may lead to overestimate the number of lesions or misinterpret the lesions, because actually, once again, what you see is not a reality, what you see is an artifact. And the size of that artifact could cover multiple slices. And it is important to remember that not every black dot on an SWI is a microbleed, and it's often not possible to obtain histopathological verification. And when you make a report, you've got to be a little bit careful with that. Examples of other types of artifacts here. This is a patient who had an intraventricular hemorrhage. You can see the hemorrhage here in the left lateral ventricle, basically making a cast of the left lateral ventricle. These are the diffusion weighted images. This is a relatively fresh thrombus where you have diffusion restriction, and the ADC map. And here you have the SWI that looks quite heterogeneous, and the minimum intensity projection. I've magnified this, and you can see these concentric rings. This is known as a 3D interference pattern. Whenever you use phase information, you have to keep in your mind that there could be interference patterns with phase information that may lead you to misinterpret or overestimate the lesions. Now, different vendors use different methods, different parameters, and different acronyms. SWI has become the hallmark of Siemens. General Electric uses SWAN, susceptibility weighted angiography. Philips uses SWI with a small p standing for phase. Hitachi uses blood-sensitive imaging, and Canon uses flow-sensitive black blood. And there may be other acronyms that I'm not aware of, but just know that the sequence is different with every vendor, and the name is also different with every vendor. And they have a different look and feel. I show you two images. Admittedly, they are not the same patient, but they are showing more or less the same area of the foramina of Monroe. In this patient, the ventricles are a little bit bigger, but these are images. Basically, both are called SWI, but they are from different vendors. And the left one is, if I remember correctly, from a Siemens, and the right one is from a Philips. And you can see that the look and feel of these images is completely different, and that you have a different texture of the image. And that is why it's so difficult to compare. Calcium can be a problem. And how can we distinguish blood from calcium on phase maps? So phase information allows us to distinguish paramagnetic substances like iron and blood from diamagnetic substances like calcium. When we produce these filtered phase images, we have images in which blood products have signal intensities that are opposite to calcifications, which are diamagnetic. And there's a very elegant paper, and I would like to pay some homage to the brilliant radiologists in Brazil. This is from a group who made this paper a few years ago, Susceptibility Weighted Imaging, differentiating between calcium and calcification and hemosiderin. And this is from their paper. You see two patients. These are the CT images. One patient has a small punctate calcification, a parasite or whatever, and this patient has some hemosiderin deposits in the right cerebral hemisphere, which are almost impossible to see. But you can see that the behavior of the calcium, depending on the sequence and the machine that you use, is quite different, oscillating between high signal and low signal, and here it is oscillating between low signal and high signal at the bottom. Now, how can we distinguish? Well, the way that I look when I'm looking at images that I'm not familiar with, I look for a reference for paramagnetic substances. So I look, for example, at blood in cortical veins. Is that black or white, high signal or low signal? Or I look at the dural sinuses in the phase image. And then I do the same. I look for a reference for diamagnetic substances. For example, the appearance of areas of known calcification. I know that the pineal gland, the choroid plexus, the dorsum sellae contain calcium. And once I identify that, I know what I'm looking at. Because to make things even more complicated, the appearance of blood and calcium on SWI is scanner dependent. Siemens and Canon use a left-handed reference scheme where blood appears bright, and GE and Philips use a right-handed reference scheme where blood products appear dark, and that has something to do with the way the copper wire inside the magnet tunnel is wound, whether it is going one direction or whether it is going the other direction. And that is an important thing to know. This, again, is a beautiful example. It comes from the website mriquestions.com, showing signal intensities of blood on a right-handed GE scanner, where this little microhemorrhage appears black, and here on a Siemens scanner, where this little microhemorrhage appears white. And that is very confusing if you're not sure. But if you just take into account what is the appearance of blood in the superior sagittal sinus or the straight sinus, then you can't go far wrong. And again, there's literature about that. We addressed this issue in our pictorial review that was published 10 years ago by Dr. Nair, who was one of my fellows. And we specifically looked at the appearance of the pineal gland on susceptibility weighted images. And so here is an example in a patient who has a calcified pineal gland, which appears black, but also a right parietal hematoma. It's the same patient that I showed in the beginning of the talk that appears to have a pepper and salt appearance, but is predominantly high signal intensity. Compared to the gradient echo sequence, the SWI shows not only cavernous malformations and petechial hemorrhages, but also associated calcifications on the phase image. And that is important if you were looking at patients, for example, with a history of parasitic disease that could have intracranial calcifications. There is a big caveat. That is that susceptibility weighted imaging may miss or completely obviate calcified cortical or dural-based lesions. Here is a focal, heavily calcified meningioma in the left pterion area that enhances avidly with contrast. And you can see it here. It's an extra-axial lesion. It's a meningioma. This is the FLAIR image. This is the susceptibility weighted image and the minimum intensity projection. And you can see, well, you can actually not see this lesion. So beware, there are things that you are not going to see. So you can never rely completely on susceptibility weighted image. It is just one sequence, and you need to understand why to use it and not to use it for other things. Here again, these are magnified views. Calcified meningioma with an intraosseous component, strongly, avidly enhancing with contrast, and on the susceptibility weighted image, it is hard to make out that there's anything there. So beware of that. The future, SWI currently is not perfect because, as I mentioned a number of times, the images, the phase image, do not reflect anatomical structures, and the contrast depends on the orientation of the object in relation to the B0 field. You must be careful with phase information, especially in complex anatomical regions. So it looks like the next step could be something called quantitative susceptibility mapping that can overcome these issues and could replace SWI even in clinical settings. It is a technique where the voxel intensity is linearly proportional to the apparent magnetic susceptibility. It is a technique that potentially allows you to chemically identify certain biomarkers, for example, iron, calcium, gadolinium, small particles of iron oxide, and that could potentially allow you quantitative stratification of cerebral microbleeds, which would be important. There's a paper published in Clinical Neuroradiology, again by Jürgen Reichenbach, 25 years later. This looks like it could be the next step. I don't have this on my scanner. I don't have any personal experience with it, but it is certainly something that we will be taking a look at in the future. And this is from another paper that was published in 2016. So there's a number of groups working on this, and there is a hope that it could make susceptibility weighted imaging even better. What should you remember? What are the take-home messages? Well, one, I think that all of you consider this as an integral part of routine neuroradiology protocols. We use it whenever there's any suspicion of intracranial hemorrhage or vascular malformation or collaterals or calcium deposition or trauma or whatever. It helps to detect micro and macro hemorrhages and to identify cerebral microvasculature and low-flow vascular malformations. It's able to differentiate calcium from hemorrhage in the brain, and that's an important asset if you remember how the phase information works. And the quantitative susceptibility mapping potentially could open the way towards quantitative assessment of neurodegenerative disorders by allowing us to identify specific chemical elements within the brain or other parts of the tissue. And with this, I would like to thank Olea for the invitation to be here. And I would like especially to thank all of you who have taken time on a busy Thursday to listen to this lecture. Thank you very much, and I close my presentation.
Thank you very much, Professor Parizel. I will be asking some of the questions that I have received from the audience. The first one is, how does the lack of standardized protocols for susceptibility weighted imaging between vendors impact the adoption of these sequences on routine imaging assessment?
It's a very good question, and thank you for that question. And that is a big problem. And the problem, and I'm not a legal expert, but I've always been told that the issue is that the original SWI sequence is patented, and protected by legal patent, which means that other vendors have had to work around this, but it is a big problem. You know that we are moving in magnetic resonance imaging towards quantitative imaging. For example, in a patient with traumatic brain injury, you would like to have a number for the lesion load in terms of the number of hemorrhages. It is very difficult to compare a Siemens with a Philips, with a GE, with a Toshiba, with whatever vendor image. So as long as you stay within the same vendor, within the same field strength, and with the same sequence, there is no issue. But if you do examine patients over a platform of different scanners, then you have a problem. And I guess the only way around that is if you plan to do longitudinal or comparative studies, that you would always plan to examine your patients on the same equipment with the same sequence.
That's a very nice link to the next question. That is, how comparable are the longitudinal studies? Is this a good technique to follow progressive disease?
Absolutely. We think it's a good way to follow longitudinal studies. And what many groups have been working on and have been kind of, and I hope I'm not going to offend anyone, but moderately successful, but not really completely successful, is to be able to express the number of lesions that you detect on SWI in a number. So could we have an index, for example, in a patient with amyloid angiopathy? Could we have an index for the number of microhemorrhages? Could we have an index in a patient with traumatic brain injury to be able to follow that? Because if you do longitudinal studies, you have to be very careful with the minimum intensity projections, because the minimum intensity projections, they basically combine a number of slices and make a thicker minimum intensity projection. And that really depends a little bit on where you are in the brain, for example. So there's a number of issues, but I think that this is a very important question. More and more we see that a lot of the stuff that we do in follow-up of brain tumors, in follow-up of patients with dementia, with traumatic brain injury, more and more we see that we are shifting towards longitudinal follow-up studies. And in that, eyeballing a lesion is not enough. You have to have a quantitative information. You could do that with various types of artificial intelligence, but I think that is where the future is going.
Perfect. I have a couple of questions on specific applications. The first one is, would susceptibility weighted imaging be useful to detect microbleeds on ischemic stroke, provided that the acquisition time is compatible with emergency constraints?
The answer, would it be able to detect microhemorrhages? The answer is yes, absolutely. And I have a talk that I've been giving a few times on intracranial hemorrhage. When we look at a stroke patient on CT and we say that it is a dry stroke, what they call in French un ramollissement blanc, so without hemorrhage, when you examine that same patient on the same day with susceptibility weighted imaging, you will find that in fact there are microhemorrhages present. The discussion, would it be feasible to do that in the time constraint of an acute stroke patient? I'm not sure. Here in Australia, there's a strong aversion to use MRI in acute stroke patients because there are not enough MRI systems to be available 24/7. So the question here is almost of no importance. but I know that in many European countries, and especially in France, there are increasingly hospitals with 3 Tesla MRI systems in the emergency room waiting to play a role in stroke. And I would like to think that it can be important, because the decision to go with any kind of thrombolysis or anticoagulation or whatever really depends on your ability to look for microhemorrhages. And that is where susceptibility weighted imaging comes in very handy.
And I have a second question on applications. Can susceptibility weighted imaging support the differentiation of radiation necrosis from tumor recurrence?
Very good question. I have to admit that I do not know the answer to that. I would have to look that up.
Okay. And one last question before we release you, everybody, is you mentioned the potential advantage of quantitative susceptibility imaging. What are the limitations to its clinical implementation?
I mentioned during my presentation, I do not have myself practical experience with that. We don't have it on our scanners at present. I would imagine that the limitations would be also the time needed to acquire the sequence. But the vision of quantitative susceptibility mapping is that you could use the combination of magnitude and phase information to get information about specific chemical nuclei, iron, calcium, small particles of iron oxide. And that is, I think, very, very exciting. And if that sequence would take longer, given the right indication and given the right clinical problem, I think I would be happy and willing to pay that price of a longer sequence if it means that I could get information about the chemical composition of the brain, which so far we have only been able to do with MR spectroscopy, but then in a very in a way that is not very spatially selective. So I think it could be something useful, but again, I have no personal experience with this as yet.
Thank you very much, Professor Parizel. Thank you all of the audience for your attention and participation, and we will see you in the next talk.
Thank you very much for listening, and hope to see you all in Perth, which is really, really the most beautiful university campus in the Southern Hemisphere. Absolutely. And a fantastic city to live. Thank you very much, and see you next time. Bye-bye.
Bye.